All right. Well, thank you for joining us. We're going to take a little bit of time here to begin with to talk about some principles of chronic disease management, focusing initially on hypertension and diabetes. But then also as we hear from Janet and from Lori, really how do we apply some additional resources and supports for our patients and clients to give them the best opportunity that we can to meet their disease management goals. All right. So again, our goals, we're going to talk about hypertension and diabetes, kind of some outlining some principles for those, discuss chronic disease management and how multimorbidity especially impacts excuse me, chronic disease management, and then again, identifying tools and strategies, resources that are available. I'm going to start with a little bit of case. This is Mrs. T, and we'll meet her a couple of times through this presentation. Right now, she's 73 years old. She lives alone. She lives at home with her spouse, and she's retired from working in a factory as management, and she currently volunteers several times a week with the Park Service. Her medical history is really pretty benign. She did have some pain in her knee, left over from an injury in her 50s while she was playing softballs and leading to some osteoarthritis. She's up to date on her immunizations and preventive health care at this point, and really is just here for an annual wellness visit checkup. In the office, her blood pressure readings, and they did an average of 3, it was 145/85. So one principle to start with when we're talking about hypertension is really to make sure we're getting an accurate reading. There are all kinds of things that people can do to raise their blood pressures in response to certainly physical activity, stress, anxiety, smoking. So we want to make sure that folks have an opportunity once they get into the office to really sit and be calm and relaxed before we start taking their blood pressure. That you rushed, you're almost late to your doctor's appointment, you're rushing in, you're answering questions, you're sitting down, and now let's take your blood pressure, holding your arm up, right? That's not giving us a good reading. So we want people to be sitting for about 5 minutes, feet flat on the floor with their back supported also. You want that cuff on just the bare skin of the arm, and you want it supported at really at heart level. So you don't want them holding it up here, but you want to arrange it so that there's something that they can rest their arm on here. Ensuring that it's also the right size, and luckily most cuffs have have a measurement device or tool in them, so you can tell if it's the right size for the person, and align so that it goes over that brachial artery appropriately. And then you do a measurement of, you do 3 sequential measurements, several minutes apart, and you average what those 3 are over that time. And that'll give you the best opportunity for getting an accurate reading. So here in the office, we got the 3 readings, and it was 145/85. So in this 73-year-old female, a show of hands, if we can, just kind of raise them up. Who thinks that this person should be started on antihypertensive medications? Or no idea from some. All right, so we got 1 thumbs up. Oh, that's right, we can use the thumbs up too as a response. Okay. So, and we'll talk more kind of about what some of the recommendations might be. We do know, though, that the prevalence of hypertension increases with age. Part of the physiologic changes that occur with aging is that you get stiffening and hardening of the arteries. You get plaques that build up within the arteries. And older adults especially are more prone to that isolated systolic hypertension. Because of this, there's increased risk of cardiovascular morbidity or mortality, including strokes, heart attacks, and an increased risk of cognitive impairment associated with it. So it is something that does have possible significant consequences. So what are our goals? And really, I think these questions, sum it up. To some extent, it really depends. This here is a list of studies that have come out really in the past 10 years that look at various outcomes associated with blood pressure control. Starting in 2008 with the HYVIT study, we're really showing that controlling, modest control of blood pressure to a score of less than, 150/80 decreases stroke, all-cause mortality, cardiovascular events, history or future of heart failure. So at a minimum, maybe that. When we look more specifically at the SPRINT trial, which kind of turned a lot of us in geriatrics on our head, that came out in 2016 and have had several subsequent subset studies. When they look at that population of people that participated in it, when they controlled blood pressures to systolic blood pressures less than 120, so really pretty aggressive control, they continue to see lower rates of cardiovascular events and death. So somewhere in between, we certainly see that modest control makes a difference, but that question is still, does more significant control make a difference? And what are the risks then associated with it? We do get worried in some of our older adults that having tighter blood pressure control really increases that risk of falls, with injury, with potential hip fractures and all sorts of things. So that being one of the bigger concerns associated with real tight blood pressure control. So based on these studies and then other groups coming with consensus criteria, again, those recommendations are really all over the board. When you start treatments, some studies greater than 140/90, greater than 160/100, which sounds pretty high to me, so good to start. What is our target then for control? Also, ranging from less than 120 in some groups to at less than 150/140. What I would really argue with this is that it really depends on your patient and your population and how robust of a population that you are interacting with. And that question then of where to start, there we go. With somebody who's moderately elevated, such as Mrs. T in this case at 145/85, that's certainly, based on all of the criteria, really is an area of concern and something that we should address. Do we need to start an antihypertensive right away on a level like that? Maybe, maybe not. I think that's that conversation with the patient of what their goals are. But definitely at least starting with some lifestyle modifications and giving that individual with close follow-up the opportunity to make some changes that will maybe impact their blood pressure and cause it to come back down into a normal or acceptable range without medications is a good place to start. They have shown, it looks like weight reduction is probably the biggest thing that could be done to lower your blood pressure. But that's per 10 kilograms lost. So 22 pounds can lower your blood pressure 5 to 20 millimeters of mercury, which is potentially asking quite a lot of folks. That's upwards of 10 to 15% of the average person's body weight. The DASH diet, which you certainly can look up and kind of go through what all that is, definitely low sodium for a core portion of it. 8 to 14 millimeters of mercury, just sodium restriction alone, 2 to 8 millimeters. So if you add several of these components together, you do have the potential to bring somebody who's, in that early, stage 1 hypertension back down into the normal range with a, committed person, obviously with close follow-up. But pharmacologic management definitely becomes the mainstay of therapy, and all sorts of options. Diuretics are still one of the first line therapies that we think about, but in our older adults, definitely pause. You're related not only to maybe some chronic kidney disease that might worsen, but also that risk that we think about of falling associated with potentially rushing to the bathroom, of orthostatic hypotension because they are higher risks of getting dehydrated. Calcium channel blockers, especially with something amlodipine, would also be something that we might consider in our older adults. Nice because there's not a lot of blood work or anything that has to be used in order to manage those medications. But then also starting to think of other side effects. Amlodipine for sure can cause some peripheral edema that we might be concerned about. The ACE inhibitors, angiotensin receptor blockers, or ARBs, it might be something we'd reach to, particularly if a person has diabetes or other cardiac disease. Beta blockers, again, with cardiac disease, might be something that you would reach for in as a first line therapy. Those alpha blockers, so the clonidine, being more non-selective, you definitely can get a lot more CNS effects. So confusion, much more increase the risk of falls. But even the alpha-1 blockers with the tirazosin, which are typically used for BPH, the alpha blockers in general would probably or should not be one of the first medications that we reach for most of our older adults, because again, thinking through that side effect profile on them. Other things to consider then in our evaluation and workup, certainly, does this person have chronic kidney disease? That might drive some of our medication selection, but also, the opportunities for controlled and renal artery stenosis. Are they at risk for obstructive sleep apnea? As we learn more and more about OSA, the long-term consequences of that being untreated, contributing to heart failure, uncontrolled hypertension, cognitive impairment, depression, difficult to control weight, certainly something that we should still keep in mind for our older adults. Is a person adherent to their medications, or are there other social determinants of health that are impacting their ability to control their blood pressure? And then, as we'll talk more, education and self-management strategies. So when do we decide and how do we decide, maybe what our goal is? And there's just a couple of things that come to mind that, I would consider in determining, am I targeting more that 120 range for my older adult, or am I thinking maybe that 140 to 150 range even is going to be reducing the risk of harm while reducing the risk of having other complications? So functional status. Mrs. T right now seems pretty robust. She's volunteering at the Park Service, so I'm guessing we're potentially a pretty active volunteer activity. She's in the community, so that higher functional status may say, hey, let's target a lower goal. What are their comorbidities? And we'll certainly talk about this more. But somebody who has heart failure or has chronic kidney disease, has had a recent stroke, our targets might be lower in response to that. And again, goals of care. And that's a thought that threads through a lot of this. What are their goals? What are their main priorities? And we might target higher goals if they have a good risk of falling, if they have fallen in their history. Again, those comorbidities, somebody who's more frail, more functionally dependent. We might have higher goals. Frailty, and then again, that risk, or not again, because we haven't talked about it yet, that risk of polypharmacy for that individual, might mean we accept a higher goal because of difficulty with managing medications or something. So if we see Mrs. T again, and she's 82, she's now been widowed for 5 years, and she's the primary caregiver for her husband. She had a fall 2 years ago and sustained a hip fracture. So we're about 10 years in the future. She's now widowed. She's had a hip fracture. She's got chronic pain. She's not driving anymore. She does need some assistance for her IADLs and has a home health aide to help with bathing. Again, she's here for routine labs, but her glucose now level is 180. Those are her current medications. So we went from, her not taking much about 10 years ago to her being on 7 regular medications. So again, kind of polling folks at a blood glucose level of 180, who thinks we need to initiate some kind of pharmacotherapy for her? Do a hands up or give a thumbs up again. Great. More folks on. All right, scrolling through the pictures there. Great. Yeah, so again, it depends. So when this, and to some extent the diabetes guidelines I think are a bit more straightforward. The ADA actually has standards for medical care in diabetes. They update them just about every year. So these are pulled right from the 2020 guidelines. And they do take into consideration all of those things we talk about when we're looking at older adults. What's their functional status? What's their life expectancy? What is their burden of comorbidity that puts them at risk for complications associated with their diabetes? And so they recommend in healthy older adults with a longer, kind of vague a little bit, life expectancy, that we're targeting fasting blood sugars in the 90 to 130 range. That's an A1C less than 7.5%. So really pretty aggressive, pretty comparable to a younger adult. As people get more complex, they get more chronic illnesses, they have more functional impairments in their IDLs or IEDLs, that level goes up. So maybe the second level, we're looking at that fasting glucose in the 90 to 150 range. As we get even more complex, those in long-term care, those with limited life expectancies, targeting fasting blood glucose less than 180 with those corresponding A1C levels. So at 180, Mrs. T needs discussion regarding treatment options. With diabetes management, they pull in the self-management concepts and those social determinants of health really right in the guidelines of what we need to be doing for those individuals. And for older adults, thinking about also how those geriatric syndromes, polypharmacy, cognitive impairment, depression, falls, how those play into that individual's ability to manage their diabetes. And they actually recommend that treatment, again, should be individualized based on all of those things. Nutrition and protein is recommended, and then lifestyle modifications as well. Talk more about those in a little bit. So medication treatment options, again, lots of potential things and more things coming on the market. Metformin still, for most older adults, is generally well tolerated. There can be some side effects with GI upset and diarrhea, but as long as kidney function is pretty reasonable, that is a good place to start, and lots of long-term benefits associated with it. Looking through the DPP4 inhibitors, linagliptin, sinagliptin, the GLP-1, or these sodium glucose co-transporters. Those are some of the newer agents out that are also lower likelihood of causing hypoglycemia in older adults, which is one of our main risk factors. So those might also be ones that we reach for earlier in our treatment options. The GLP-1 and the sodium glucose transporters have also both been shown to have benefits with cardiovascular risk, so we might choose those in somebody who is high cardiovascular disease, already has known cardiovascular disease. And we really want to avoid ones that are going to contribute to low blood sugars, like the sulfonylureas or this one that I crossed out and I can never say, so I apologize. Because of that risk of hypoglycemia associated with them. I did not cross the sulfonylureas out because for some people they may be an option, but we really want to reserve those for folks where that's kind of the last option because they've exhausted some of the other ones. I would also add that the DPP4, the GLP-1, and the sodium glucose transporters, cost is also often a barrier for people to use those medications. So something to consider. And then insulin regimens, if people can't be controlled on their oral medications, then we do look to those insulin regimens. So for Mrs. T, we might consider starting at least with metformin. She doesn't have a lot of cardiac burden. Kidney function seems to be doing okay. We obviously would verify, but that would be a good place to start, and then to titrate that medication as she tolerated or to her current renal function. So we come across her again about 5 years later. She's now living in assisted living after she did have a stroke about 2 years ago. She had another fall and fractured the other hip. She does have early stage dementia and is needing reminding or assistance with some of her ADLs, combination of cognitive as well as those functional limitations. The facility now is managing her medications. And just to put it out there, right? I mean, she's got some early memory changes and her family is now talking about, asking about some treatment for dementia. When we look at her current medications, again, we add in a stroke. She's now in a facility. She's being treated for her diabetes. So her list, continues to grow of medications for her. And so one of those questions may be, as we're looking at her illnesses, as her multimorbidity, is adding more treatment for her dementia appropriate for her care? And how do we do that? So these guidelines are, so what we know about multimorbidity is that 50% of older adults have 3 or more chronic illnesses. And according to the NCOA, 80% of older adults have 1 chronic illness. And you can see hypertension, high cholesterol, arthritis, all of those things are really common. That multimorbidity is associated with death and disability, risk of winding up in a nursing home or other facility, greater use of healthcare resources, and general poor outcomes. And what the challenge is, right, we have all these guidelines, looking at hypertension alone, looking at diabetes alone, looking at stroke management alone, but there's really not a lot of evidence that suggests, like, how do we put all of these pieces together for an individual and, risk stratify treatment principles. And how do we share in those decisions, shared decision-making with our patients and our families, particularly when there's, a 10 or 15 minute office visit, reimbursement issues come into play there too. And so the American Geriatric Society really created this multimorbidity framework, which, as I've alluded to a little bit, really is all centered around what is the patient goals and wishes for their care. So the first step is really, again, assessing the patient preferences for what their care is. So if we talk to Mrs. T, or we talk to Mrs. T and her family, would be my strong encouragement. What is the goal for her care? And maybe Mrs. T, says, I just want to be comfortable. I want to be able to go down for meals. I want to be able to play bingo. But I don't want a lot more medicines because I'm already taking like 10 every day. And then evaluating, based on those preferences, really evaluating the evidence for things. Does the evidence in each of these individual studies or in the recommendations really apply to my patient sitting here before me? A lot of the literature, though there's increasing every day, of how these disease management is optimized in older adults, it's still hard to find ones that have a large population of 80-year-olds or of 90-year-olds or of 100-plus-year-olds, and we're seeing more and more of those every day. So what do we do in that population, and can we apply this? Assessing the prognosis, and is that prognosis met by whatever potential benefit the disease management may provide? And is it clinically feasible? Again, based on, on those care preferences, on where the patient is individually, does it make sense? Mm-hmm. Then we optimize the plan. And what I like kind of on my graphic here is that it's not a one-time conversation, right? This is something that we should be doing. Maybe it's not a 20-minute conversation every time, but it's bringing these principles back up with new questions, with new treatment options, with new evaluation options that the individual, presents to us with. So that is kind of the principles as recommended, through the American Geriatric Society and others, of how we apply this to older adults. So I'm going to pause myself from talking, and I think I need to switch PowerPoints real quick. I'm sorry, they were merged, and I think I pulled up the wrong one here. So give me just a second, and then Janet, we're going to pass over to you.
Okay. And you're going to put the PowerPoint up, right?
I am. Yeah.
Okay, great.
Start over again here.
So My name is Janet Raber. I'm a registered nurse, and I'm also a certified diabetes educator. I started working here at NEOMED about 1.5 years ago as clinic manager for a student-run free clinic. Now, our student-run free clinic serves the uninsured and underinsured populations in about 5 counties around NEOMED. We have a very small population of older adults, but I bring my other experience as education coordinator at Suma's Family Practice Center for 28 years. And also as a side job, I do assessments for long-term care insurance. So I go in and I do a cognitive assessment, physical assessment, ADLs, IADLs, and things like that. And I've also worked with the geriatric department here at NEOMED for several years, working on a geriatric workshop for the medical students. So that's sort of my background, and I'm just going to go over some tools for chronic disease management in older adults. And so the next slide, it would be, do I have control over the slides? Okay. So barriers to self-management. So, you know, the goal is to keep the people safe, keep the people independent, keep the people happy and fulfilled, and then keep the people out of the hospital as much as possible. And in the place that they want to be, whether it be their home or assisted living or wherever. So self-management is really a key tool to, you know, doing all these keeps. So barriers to self-management. Basically, lack of confidence in their skills and knowledge. They don't think that they know that they could learn how to do some things, and they don't know what they don't know. And you know, a lot of patient education becomes involved in that when it comes to teaching them new skills, whether it be using a blood pressure monitor, or a glucose meter, a pulse oximeter, or whatever. At this time, they may have some vision and dexterity problems, especially if they have diabetic macular degeneration, diabetic retinopathy, if they have arthritis with the dexterity problems. So, you know, those take into play with, are they able to do the things that we're asking them to do? A lot of our geriatric patients, they have no access to Wi-Fi or a smartphone, or if they have a smartphone, they don't know how to use it because they're old dogs and they can't learn new tricks. And so I'm sort of in that category. I'm learning every day how to do this. That's why Jen is doing the the PowerPoint for me. So they may not have any caregiver support. So loneliness and not having caregiver support is a big thing then too. And they may or may not qualify for some skilled nursing for education or for even home health care. So in order to qualify for home care, you need to have a need for skilled nursing. And so, you know, people with long-term health care insurance, they tend to be wealthier and were able to spend money for this insurance, and their long-term care insurance will sort of kick in and provide, you know, home health aides and other home benefits. So so that's a nice thing for them. But in our population at the free clinic, most of our people, you know, struggle with social determinants and food insecurities and things like that. So it's not a benefit that they have. All right, next slide. So one of the big things is medication management. So we talk about medication adherence, but there are lots of barriers to, you know, adherence, and you know, one being cost, and the other being access, you know, to getting them, and the other being, you know, being on time and dosing properly. So some of the tools that you can use are just a pill box. And it's helpful if somebody can help them manage their pill boxes and put the right pills in the right day and the right times and all that other stuff. DocuDose or prepackaged dose things from the pharmacy is a great way to do that. Again, it's always, do they remember to take them at the right time? The nice thing about the DocuDose is each day has, their appropriate doses, and then and they're like packaged in like easy tear envelopes, and the envelopes are identified with the name and the dose and what time they should be taking the pills. So that's a really good thing to do. Again, it costs a little bit more, and they may or may not qualify for that. A cool thing that I saw at an assisted living facility where the person was managing their own medications, so that the assisted living facility was not giving them, but the pharmacy provided them with, it looks like a little cash box. And inside the cash box, it has a timer and an alarm and a lock on it. And so the alarm goes off, it unlocks, and then it opens up and it gives you your medications as you need it. And I thought that was pretty cool. So that's that combo pill box with the alarms. I encourage people to set an alarm on their phone if they can use their phone that way, or set an alarm, on their radio or whatever, to take their pills. I also encourage them, like if they take their pills with meals, then they keep those pills in the kitchen. If they take their pills first thing in the morning, then they put it by their toothbrush. So those are some, ways that you can help them remind it. If they take their insulin at night, then they put their, they keep their insulin at their bedside. So those are, where do you take your pills? What time do you take them? And what's going to trigger you to do, that you do. So a lot of people will put their pills right by the coffee pot because that's the first thing they do. Pharmacy auto refill programs. So the pharmacy sort of helps track, and I know that there are some pharmacists in this group, and thank you very much. The pharmacy auto refill programs, where they sort of keep track of what needs refilled, and they automatically refill them, and then they notify the patient that they're ready. And then mail order pharmacies with auto shipping, those are really nice. Comes right to the house. They don't have to worry about it. So next slide. The other thing is home monitoring. So with diabetes, you can offer them a glucose meter, teach them how to use it. We also want to manage their blood pressure. So we offer them a blood pressure monitor because we know that diabetes and cardiovascular disease goes hand in hand. And then offer a scale so that they can keep track of their weight. And the scale for CHF is really important because they need to do daily weights, and they need to follow their weight and their dry weight and water weight for CHF. And then with CHF, giving them a pulse oximeter and obviously a blood pressure monitor along with the scale. And then coagulation therapy. A lot of people with CHF also have atrial fib, and they're on Coumadin, and they need their PT-INR, and there are home monitors for that. All of these require a lot of teaching for the patients, some dexterity for the patients, but it really gives them an independence, and they're not running back and forth to the hospital. Many of these monitors and meters can be hooked up to computers, and they can all the monitors and even the scales can send things remotely to the providers. Now, most of the patients that I've dealt with really can't navigate that whole system, and so it's important that you have good communication. So next slide, please. So basically, they have the needs for these patients is that they need training on the use of the monitors, and try to involve as many family members or caregivers as possible so everybody is on the same page, everybody can help out. Panic calls from my mother-in-law, you know, was very frequent. It was like, I can't get this to work. What am I supposed to do? So if a couple people know what they're supposed to do, then it helps. Access to the monitors and all the equipment needed, you know, like alcohol pads, lancets, Band-Aids, cotton balls, and test strips, and all those kind of things. So they need to have access to that. I know with like the PT-INR monitor, there's a whole quagmire of paperwork that you have to fill out in order for them to qualify for that. So, you know, navigating through all the paperwork to get in, and maybe pre-authorization or authorization for those. They need to have an easy logging and reporting of their monitor readings, okay? So give them access to a calendar that they can write their numbers down on. Ideally, the primary care provider is their medical home, and the primary care provider manages all of these reports, you know, and then communicates to the specialist as needed. So if they're, you know, now in cardiology, I know they have like a CHF clinic, they have a Coumadin clinic, they, you know, so cardiology might be heavily involved in that, or you might want to just give it all over to cardiology. Endocrinology, they don't want to know everybody's daily blood sugars. They want to know that, you know, 3 to 6 month visit, you know, what your A1C is. So pretty much primary care should follow the blood sugar reports and do appropriate titration of their medications. So easy communication is the key. It's, you know, easy path to the provider for follow-up. Usually involves a nurse or an MA to, you know, record all the reporting. What we did, we had a dedicated voicemail. And so they got to bypass, you know, the call center, they got to bypass the telephone operator, and they could just call right in, and they know that it's a voicemail, and they're going to leave a message. They're going to leave their name, their numbers, and then any other issues that they might have, and then they'll get a call back within 24 hours. So timely follow-up to their reports for their medication titration. So especially if you're titrating their blood pressure medications, or you're titrating their diabetes medications, or titrating their Coumadin dosing, you know, it really needs to be timely so that, you know, things don't get out of hand. We have one patient that would call in and, you know, audibly short of breath and had a 5-pound weight gain in one day. And, you know, and she did have a treatment plan for her CHF, but she always wanted to double check with us. And so we would, you know, get on her anytime she called. We would get on her right away. And we kept her out of the hospital for many, many times just because she was so good about calling in, and her medications and her weight and her blood pressure readings and her glucose readings. Talk about comorbidity. She had it all. And then education is key, as you know, what's a critical reading, and when they should call like the direct line, or when they, you know, when they're going to leave a message. So if they have a critical reading, they're supposed to call the direct line and tell them that, you know, I have a critical reading. And that seemed to work out really well. Okay, next slide. I think we're, okay, so at the Student Run Free Clinic at NEOMED during COVID, we switched over to telemedicine. So basically what we did was all the patients with hypertension and or diabetes were offered a blood pressure monitor and a glucose meter as needed. And then the monitors were mailed out with handouts. and then a student educator would contact the patient to do the training on the meter and to discuss the handouts and discuss rationale and reporting. And then they were given the reporting number to do that. Chronic disease management continued without having an in-person visit to the clinic, which was great. So we could continue to manage their chronic disease and titrate their medications and not lose that, that inertia that we started and not fall back into clinical inertia. Patients appreciated the contact with the students and they feel connected to the clinic. And so that was a very positive thing. And then students found that the contact with the patients was very fulfilling. And then we got objective readings, we got vital signs, and we got monitors, and we got test results, you know, and without the need for them having to go into the lab and be exposed possibly to COVID. And so we were trying to keep them at home, safe, and without having any external exposure by coming into the office or by going into the lab. In this way, with the monitoring, we could do that. All right, and I think that's our last slide. I just wanted to comment on something that Jen was talking about, how we, the medication and the criteria for starting medication. My father had moderate to late Alzheimer's disease and ended up with a high glucose level. And his very astute primary care physician was following the guidelines for, you know, a healthy individual, and put him on glipizide. And it told my mom that she had to check his blood sugar 3 times a day, which he hated, and he fought her tooth and nail for each one of those things. And you know, essentially, he ended up having seizures from hypoglycemia. So it was not a pretty picture, and I was very frustrated with the doctor because he didn't take into consideration all the comorbidities with going on. And he probably didn't take into consideration that my mom followed his direction tooth and nail and would not back off of testing his blood sugars and giving him his meds and all that other stuff. And she also took away all of his sugar then too. So it was pretty sad to see him end up in the hospital with hypoglycemia and seizures when he was so confused with his Alzheimer's. So really take those kind of things in close consideration. And that's all I got to say. So thank you.
Lori?
Lori?
All right, thank you. I will share my screen here. Bear with me a moment. So, first of all, thank you for having me here. I really appreciate the opportunity to come in and share this information. My name is Lori Smith. I am the training coordinator with Direction Home Akron-Canton Area Agency on Aging and Disabilities. If you are not familiar with what an area agency on aging is, our overall goal is to help people, older adults specifically, be able to stay in their homes or age where they would like to be, rather than having to go to a long-term care facility. And if that's their choice, if they would like to go there, we can help them with services and supports there as well. But that's our overall goal with an area agency on aging. My piece in this is to offer preventative education, and that's where you see the Healthy You and Steady You. We work with the Ohio Department of Aging with funding through the Older Americans Act to be able to host these classes. We offer them to people in the community, and they are all free to attend. In the normal world, we do these live and in person, but with COVID, we of course want to keep that older adult population safe and healthy. With them being a high-risk population, we have moved these to online, and we'll get into that in a little bit. We have several categories of these classes that the Ohio Department of Aging calls Overall, they're called our health wealth programs, but they have split them into a couple of categories. The first is the Healthy You, and that is our chronic condition classes. The first is Chronic Disease Self-Management Program, or CDSMP. And then we have another one that drills that idea down specifically to look at diabetes. We do talk about both type 1 and 2 diabetes, but the larger of the focus is with type 1 in that class. And then the next category is what they call Steady You. And these are our falls prevention classes. The first of those is A Matter of Balance. And then we also offer a Tai Chi Moving for Better Balance program. And then we also do powerful tools for caregivers. That doesn't really fit into either the Healthy You or Steady You programs, but we do want to make sure people are aware of that. We'll get into a little bit about what that talks about too. All of these are evidence-based classes, and all of them are led by trained and certified peer volunteers. And what we mean by peer volunteers is, even though I may be a professional or a medical professional might be leading these classes, but in the role of a leader or a coach for these classes, we want them to take that professional hat off and really be a peer to these older adults that are taking this class. That also comes with the caveat that if you are a medical professional and leading these classes, they're not your patients, so you cannot give them medical advice tailored to them. So that's why we ask that it is peer-led. All of these classes are co-led by 2 volunteers, with the exception of Tai Chi. That is the only one of these offerings that is led by a single person. And then, as I mentioned, they are free to attend for all the participants. And then when we are live and in person, we take them to different venues. There's no charge to that venue either. And that's where the funds from the Older Americans Act Title 3D funds come in. So we're going to talk first about the Chronic Disease Self-Management Program. All of these are multi-week programs. This one in particular is a 6-week program, and participants meet once a week. Each session ranges about 2.5 hours per session. That sounds like a large chunk of time, and it is. But there is a lot of information that goes along with that. It can vary a little bit from week to week. Some weeks have a lot of information that we discuss and some not so much. But the target audience for this is community dwelling older adults who are experiencing a chronic condition, as well as their caregivers, because we want those caregivers to get this firsthand knowledge and education as well, so they can help them along that path. And things that we talk about during this particular class, we talk about 1, stress management, because we know stress can really exacerbate these chronic conditions. We talk about how better nutrition can come into play, very much so, being physically active, how to have an open, honest, and clear communication with your healthcare team and with your family members and caregivers, because we know that is really important as well. How to manage any medications that you might be taking. And this, as you can probably guess, is a pretty broad class because it's not geared toward any one in particular chronic condition. So it is generalized. If people want some information based on a specific chronic condition, they can ask us and we can give them information. But again, if a leader is a medical professional, we can't go ahead and give them specific to them advice or treatment options. Let's see here, slides decided to stop. So the next one in our Healthy You is diabetes self-management. Both this and the chronic disease self-management were designed by Stanford University. And this one is taught very much like the chronic condition self-management. It's just drilled down specifically to look at diabetes. It again is a 6-week program, meet once a week for 2.5 hours a session. And here again, the target audience is community dwelling older adults that have either type 1 or type 2 diabetes, and again, their caregivers. Again, even though we do talk about type 2, more of the focus is towards type 1 because that is more the chronic disease type diabetes. We still look at stress management, having communication with your healthcare team. The nutrition portion is geared more toward how a diabetic should approach nutrition, so that is a little bit different. We talk about using those monitors and any medications specific to diabetes, whether it's insulin or something else that would regulate that blood sugar. And both of these are very interactive. We do brainstorming activities, we share ideas, and it really gets in depth. We talk a lot about the emotions that somebody might feel once they're diagnosed with diabetes or with a chronic condition, any chronic condition that they're going through. The emotions, the roller coaster once you're diagnosed with this chronic condition, what that might feel like, and how to work through those emotions. That's also a very important component to these classes as well. So now we're getting into our falls prevention workshops, and this is a matter of balance. It, again, is a 6-week program. We meet once a week, and this one is 2 hours a session. Target audience for this one is, again, community-dwelling older adults who have a fear of falling. And what this one focuses on mainly is breaking what's called the fear of falling cycle. And if you're not familiar with what that is, research has found that if someone has that fear of falling, whether it's because they have indeed fallen recently or they just feel unsteady for whatever reason that might be, when they have a fear of falling, people tend to not be as active. They may stop doing things that they enjoy doing because they feel they might fall. So that in turn, you become less active, your muscles weaken, so you become less active. Staying in and not socializing like you used to can cause depression, which can exacerbate any chronic condition you might have, increases depression, and round we go. So we really look in this class at breaking that fear of falling cycle at any point in that cycle, and we do look at different points and where we can step in and stop that. There is an exercise component in this that is introduced in the 3rd session. It is not, I always tell people, don't think we're going to be running a marathon through the streets. These exercises are small movements that can be done either sitting in their chair or standing right there, holding on to a chair or at their desk. Now this does say, we do ask that people are fairly mobile for this class. Using assistive devices is okay, and any of these movements that we introduce can be modified so they can do it completely from a seated position if need be. So that is a possibility as well. The second of our falls prevention classes is Tai Chi Moving for Better Balance. This is the longest program that we have by far, with 24 sessions. We do have the option of meeting either once or twice a week, and each class is an hour per session. Here again, our target audience is those community dwelling older adults who have that fear of falling. And here again, we do want them pretty mobile. That being said, I have had classes with people who have been in a wheelchair. So all of these movements can also be modified to be done completely from a seated position. They are still using their arms, they're twisting from the torso, they can still lift and position their legs, so they will still get those benefits of strengthening the muscles, and improving balance if they are able to stand for short times, and improving flexibility. This program is based on Yang style Tai Chi, and participants learn 8 forms of that Yang style Tai Chi. These have been specifically picked to go from a fairly simple form and increase its complexity as the forms go along. They are also modified just a bit from straight and strict Tai Chi to focus on those people who have that fear of falling. And then we also have our powerful tools for caregivers. This is a 6-week program. We meet again once a week for an hour and a half per session. Now there is an option for a longer class. My co-leader and I that give this class, we've always stuck with the 1.5 hours per session for a couple of reasons. One, it's a long time, especially for caregivers, to sit down and commit, because we all know their lives are really busy and really chaotic and things pop up. So we try and keep it as short as we can and keep fidelity to the program, because again, this is evidence-based. Our target audience here are those family caregivers. All of our other programs are focused on the patient or client that is having an issue. Here we realize that family caregivers also need care. They're going through a lot of stress financially, maybe within their relationships. So we want to focus on them. And throughout this class, we really focus on those difficult emotions that caregivers go through that, we don't even really want to admit we feel. We feel frustrated sometimes with our situation. We can get angry with the situation. And we look at positive ways for that caregiver to get through all of these difficult emotions and difficult situations that they are now in, and allow them to say it's okay and actually really necessary to slow down and take care of themselves so that they can be a better caregiver. So again, most of these classes with COVID-19, we have been able to take virtual, and here on this slide, you can see the ones that we've been able to do that. And it really is all with the exception of Matter of Balance. The program developers of Matter of Balance feel that the exercise portion is better led in person. So they have said no to virtual. Everything else we've been able to turn over to virtual, and we do use Zoom to do that. Now, as Janet mentioned, there are a lot of our population that don't have access to the internet, or they don't have a device that they can join us on Zoom, or they just don't know how. And that has been a barrier for us that we are looking at ways to move past. But so far, these classes have been quite successful and very well attended. We do keep the class sizes small, and we'll talk about that a little bit too. But they have been in demand and pretty well attended. And along with the information given with these evidence-based classes, we are also finding that it's got a fantastic secondary benefit of helping people with social isolation, especially going into winter, where we can't even get out now to take a walk in the park or do things outside that the warmer months allow us to do. And we all know here that it can be, people can decline cognitively, depression can kick in when we get really socially isolated. So even though we're not seeing people in person, we still do get the benefit of seeing faces, having conversations, and a lot of these classes get really personal, so you feel like you're making these connections with other people. You understand, you don't feel alone in this situation, and that has really become a benefit. As I mentioned, we do keep the class sizes small. When we do them live and in person, that is a piece of the evidence-based program, that they are small. And that is because we do a lot of brainstorming and a lot of idea sharing. And we want the class small enough so that people don't feel lost in this huge group, and they feel like they're heard, they're validated, they have these ideas that count. So we do keep the class sizes small. We have found where when we were doing them in person, people had to think about transportation. How far do I have to drive? Do I even have transportation? But with Zoom, we're not limited to a physical location. One of my Tai Chi classes, I had somebody from Florida log in and I had somebody from Texas log in. Obviously, they wouldn't have been able to do that when we're in person. We do really stress that confidentiality is of the utmost importance. Again, that's because we do share a lot of very personal and private information. We let them know that we as the leaders are not going to go back and discuss this with our coworkers at any point in time, and we do ask that when the classes are done, it's not shared between the participants and their family members or friends either. We want people to know that these classes are a quiet, safe place to share their feelings. And we don't record the classes either for the same reasons. All of the classes, webcams are optional. I've not had a class yet where somebody has not turned their webcam on, again, because one, the class size is small and we are doing a lot of sharing, but we still do let them have the option of turning their webcam on except for Tai Chi. And that's because it is solely a movement class. All the others were sitting down. The participants have a manual that they're getting information from. Most of the class is, you know, a lecture or a give and take. Tai Chi is all movement. We're standing up, we're moving, and I want to know visually that these people are safe. I also let them know that if they have to leave the screen for any reason, please verbally let me know, because if I don't see you, I've collected their phone number and a safety contact phone number as well. And if they disappear off screen and I ask if they're okay and I don't get a response, I'm calling. And if I don't get a hold of them, then I'm calling their emergency contact. And if their emergency contact is far away, I'm calling 911. And again, it's for safety. We're up, we're moving. These are people who have a fear of falling. So I just want to make sure that they're safe. That's why we require the webcam for Tai Chi. We talked about the small group discussion, brainstorming, and idea sharing. Zoom also allows for the use of a whiteboard where we can do those brainstorms and they can see the ideas being jotted down. And that kind of solidifies things, makes things easier to remember. You know, some people are auditory learners, some are visual learners. Both coming at you just helps you to really absorb the information. And then I have learned to build the demographics info and the liability form into the registration. I used to send it through a fillable PDF, and I ran into the problem of people not returning that. And because these are evidence-based classes, I do need to collect a little bit of demographics information. So I've learned to just build that into the registration form. So I've got it. I don't have to worry about people sending it back to me. This is just an example of part of the registration that is built. This one is for Tai Chi. You collect just the basic things, name, email address, where they are. As you get down to the bottom of the screen, you can see where it starts to get into more of the demographic information. Here's the rest of it. We do ask, you know, do you have a chronic condition that we need to think about? Any functional limitations, so I can make sure that I'm also giving them movement modifications if that is a concern. 4 or more medications, again, because of that increased falls risk. Have they fallen in the past month? Are you afraid of falling? And do you restrict your activities because of a fear of falling? And then that last thing there is the little liability, that they understand this is a movement class, there is a risk. So they do absolutely understand that. So that wraps my part up. Are there any questions? I've got my chat window open. I can see any questions. If not, I will turn it back over.